Assalamu alaikum. I am Dr. Hafizan, presenting my today's presentation on renal mass. My moderator is Dr. Irfan. My learning objectives: epidemiology and risk factors, clinical presentation of a renal mass, investigations to understand paraneoplastic syndromes, staging of RCC, and idea regarding renal mass biopsy. Epidemiology: a large population-based study using MRI found an overall prevalence of renal cysts of 34% in males and 21% in females. Renal cyst prevalence increased from 14% in the youngest age group from 20 to 29 years to 55% in oldest age group 70 years for males and from 7 to 43% for females. Increasing age, male sex, and renal dysfunction are known predisposing factors. Autosomal dominant polycystic kidney diseases. Autosomal dominant polycystic kidney disease is a systemic disorder characterized by progressive transformation of both kidneys by numerous cysts, leading to gross enlargement and distortion of both kidneys. ADPKD leads to slowly progressive chronic kidney disease and is one of the most common causes of end-stage renal diseases. It affects 12.5 million people worldwide, or 1 in 1,000 to 2,500 persons on average. Benign renal masses, oncocytoma. Oncocytoma is a benign renal tumor that accounts for up to 50% of small renal masses less than 4 cm in size and represents the most common benign enhancing renal mass. Most oncocytomas are found as asymptomatic unilateral masses within the renal cortex and are hard to distinguish from RCC, in particular chromophobe RCC, based on imaging characteristics. Although most oncocytomas are sporadic tumors without any other identifiable pathology, oncocytomas can also present in the context of Bird-Hogg-Dube syndrome, an autosomal dominant inherited disorder characterized by mutations in the folliculin gene on chromosome 17 with variable penetrance. Benign renal mass, angiomyolipoma. AML is a benign mesenchymal tumor composed of variable proportions of dysmorphic blood vessels, smooth muscles, and adipose tissue that arise from the cortex and medulla. These tumors can occur sporadically or as part of genetic syndromes, most commonly tuberous sclerosis complex and lymphangioliomyomatosis. Prevalence at 0.13% in the general population, with a female predisposition and a peak incidence in the 4th and 5th decades of life. Papillary adenoma. Renal papillary adenomas are unencapsulated low-grade tumors with papillary or tubular architecture of 15 mm in size arising from the renal cortex. Given their small size, they are nearly universally found incidentally on cross-sectional imaging or found in nephrectomy specimens for larger renal masses. The incidence of papillary adenoma increases with age and it is more commonly found in males. Metanephric adenoma. Metanephric adenoma is a rare, benign epithelial lesion of the kidney, accounts for 0.5% of the adult renal neoplasms, mainly described in case reports and case series. Leiomyoma. Very rare, benign smooth muscle tumor of unknown etiology. They account for approximately 0.3% of primary renal masses with a female predominance of 2:1 ratio. They most commonly arise from the renal capsule, although lesions with different origins, such as the renal pelvis and vein, have also been reported. Malignant renal tumors. Renal cell carcinoma ranks 14 on the list of cancers, representing around 2% of all cancers, with the highest incidence occurring in Western countries. In 2022, there were an estimated 434,840 new cases of RCC globally, with 155,953 deaths worldwide. Incidence and mortality are highest in Europe and Asia, and it is more predominant in males. Risk factors. So there are two types of risk factors, modifiable and non-modifiable. So we'll first discuss modifiable risk factors, which include smoking, obesity, diet, alcohol, hypertension, occupational exposure, and drugs. And non-modifiable, we have age, sex, and race. Age, most patients are diagnosed between 55 and 75 years of age. RCC develops in about 50% of patients with VHL disease and often in third to fifth decades of life and bilateral and multifocal involvement. It is more common in men. Male to female predominance is 1:1, and they also have lower survival rate. Race: African Americans and Hispanic Americans and Native Americans have a greater risk of RCC than white Americans. Clear cell RCC is more common among Caucasian Americans, while the papillary subtype is more common among those of African or Caribbean descent. Now the modifiable risk factors: smoking, carcinogens such as polycyclic aromatic hydrocarbons and beta-naphthylamine and nicotine filtered through the nephron. These particles are metabolized and promote inflammation and induces DNA damage, paving the pathway for carcinogenesis. Obesity: the precise pathogenesis remains unclear, promotes resistance to insulin and insulin-like growth factor, facilitating uncontrolled tumor growth, releases inflammatory cytokines and disrupts the metabolic hemostasis, such as stimulating the release of adiponectin, leading to the overproduction of DNA-damaging free radicals, ultimately leading to carcinogenesis. Diet and alcohol: the correlation between diet and RCC, however, seems to be not as strong as in other neoplasms like gastric and colorectal cancer. Diet heavy in meat-based protein and fat and dairy are associated with higher risk. Heavy drinking is associated with increased risk among both men and women. Hypertension: hypertension damages the renal glomerulus and tubular apparatus and has been associated with increased risk of kidney cancer. Time since hypertension diagnosis and poorly controlled hypertension both significantly further increase the risk of developing RCC. Time and uncontrolled hypertension. Occupational exposure: RCC is not classified as an occupational neoplasm like bladder cancer or mesothelioma. Most trichloroethylene, a solvent used in degreasing agent, spray fixatives for art and public drinking water, has been associated with RCC. Other: asbestos, benzene, vinyl chloride, herbicides, and cadmium. Drugs: overdose of acetaminophen and NSAIDs are associated with RCC. These agents inhibit prostaglandins, which are necessary for proper kidney function. Clinical presentation: incidental finding, most commonly on abdominal imaging. Benign renal tumors are an ever-increasing and common entity in urology clinic because of the widespread use of abdominal imaging. Over half of such renal tumors may have no symptoms and more likely are confined to the kidney. The classic triad of symptoms, which include the flank pain, hematuria, and palpable abdominal mass. Flank pain, hematuria, and palpable abdominal mass. The classic triad of symptoms is now rarely seen because of increased use of non-invasive imaging, ultrasound abdomen, thus detecting the disease at an earlier and curable stage. These constellation of findings, when present, almost always denotes an advanced disease. Therefore, some refer to it as the too late triad. Patient may present with advanced disease include constitutional symptoms such as weight loss, fever, night sweats, malaise. Rare presentation: spontaneous perirenal hemorrhage, underlying mass may be obscured. Mostly an RCC or AML is present, which is diagnosed on a repeat CT after a few months. If metastatic disease, it can occur with bone pain, persistent cough, or paraneoplastic syndromes. Other important physical findings include the palpable cervical lymphadenopathy, usually showing advanced disease, bilateral lower limb edema, usually resulting from inferior vena cava involvement, and a varicocele, a right-sided varicocele and a non-reducible left-sided varicocele, point towards a renal mass which has involved renal vein. Approximately 30% of patients with RCC present with metastatic disease. The physical examination should include a thorough evaluation for metastatic disease, particularly in the following organs: lungs, soft tissues, bone, liver, cutaneous size, and central nervous system. Lungs being the most common, 75%. Lab workup: complete blood count, urea creatinine electrolytes, GFR, liver function test, serum calcium, erythrocyte sedimentation rate, urine analysis, alkaline phosphatase, spirit renal function using renal scintigraphy, Other tests as indicated by the patient's clinical picture, for example, paraneoplastic syndrome workup.
Assalamualaikum. So can anyone tell me why a split renal function is needed in patients diagnosed with renal cell carcinoma or any carcinoma of the kidney? Why do we need a split renal function? Yes, Kayum.
Because mostly patient diabetic, multiple comorbid hypertension, and we don't know the exact functions of the normal kidney. We need maybe critical nephrectomy. Dependent on symptom of kidney.
Okay. Very good reasoning. Anyone else who wants to expand on what Dr. Kayum said? Why do we need it? Split renal function before managing an RCC. Why is it important? So let's say we do the split renal function and the right kidney is affected, right? But then we find out that the left kidney is only 10% functioning and the right kidney is 90% functioning. Is it going to change your management? It's going to change your management, right? We might try to go for a partial nephrectomy. We might go for a heminephrectomy in the affected kidney. Or if it is unsafe to keep the right kidney, based on the nephrometry scores, we have to work up the patient. We'll have to prepare the patient post-operatively so that he can be properly counseled and guided that he might need dialysis post-op. Okay, so we'll get an AVF done, we'll get a permacat done, we'll guide the patient. Okay, it's very tough it's going to be very difficult for the patient that you've removed one kidney and then post-operatively you find out that he has to undergo dialysis now. Okay, so that is why it is very important to determine the split renal function before thinking about the management. Yeah? Let's go.
Thank you. Imaging modalities, ultrasonography.
Sir.
Do we have any, in every patient we should do the split renal function, or is there any specific indication for doing the specific split renal function in RCC patient?
I said, I haven't read anything about any specific, the baseline workup for an RCC recommends it. No, currently, we are, I mean, we're not doing it. It should be, I think because the baseline, that is the recommended guidelines and the books are recommending split renal functions as a baseline.
Imaging modalities, ultrasound, contrast and a CT scan of the chest, abdomen and pelvis, considered gold standard. MRI, if venous involvement is suspected or patient cannot tolerate contrast. Renal arteriography, now rarely used. Venography, MRA, bone scan if bone metastasis is suspected or ALP levels is raised. Brain CT or MRI if patient has clinical manifestations suggesting brain metastasis. This is a CT image showing renal mass on the left kidney on the upper and mid pole.
So, can anyone tell me what we see in a CT scan and what do we look for when we're looking CT with contrast in the renal mass? What are we looking for?
So first of all, we will see the both kidneys, and as this is the CT contrast, we look for the uptake of contrast. Either it's enhancing or it's non-enhancing.
Yes. Okay. So the first thing that we need to see is not the CT with contrast. The very first film that we're going to see is the CT, is the plain CT, the scout CT. Okay, without the contrast. Okay, and then it's going to give you an idea if there's a mass or not. And so, can anyone tell me what are the phases of a CT scan, a CT with contrast? What are the 3 phases that we have? Very good. We have an arterial phase, and we have a venous phase, and we have the delayed phase, or what we call the excretory phase or the urogram phase. Okay, so if we're going to be looking at RCCs, we're going to be looking at RCCs in the arterial phase. So most often there is 15 to 20 Hounsfield unit increase from the scout film as compared, when we're comparing to the scout film. So that is the differentiation that we make. That is the basis of the radiological diagnosis of RCC on a CT scan. Okay.
And also the shape of the mass. Usually this rounded shape and the more common in the upper pole. It's usually RCC. Sir, I read it in a book that where we are seeing the CT images. So we have to see multiple modality like Hounsfield units. We have to see the shape of the mass. We have to see the location of the mass, either it's having a tissue component or not, or fat component or not, and also the size of the mass. If it's usually rounded, it's more likely a malignant suspicion of UL towards RCC.
A rounded mass usually tells you that it's an encapsulated mass. That is the basis of it.
Of those writers are explaining what are the characteristics, so you can tell on just a CT angiogram or a CT CAP that with 3 phases that Irfan was mentioning, that this particular mass is an RCC, renal cell carcinoma. It's what are the differentiating mass? Like you say, okay, this is not an RCC. What it could be then?
It could be a leiomyomas. It could be an
Benign, or it could be upper tract TCC.
Yes.
Right. So most of the time you have to differentiate between these two to 3 entities. So these are the differentiating point. You must know that he was mentioning about 15 to 20 Hounsfield unit and the early blushing of that. In cases of upper tract TCC, you may see contrast enhancement, but blushing is not as you see in the RCC. Even in venous phase, contrast is going to retain when we're talking about upper tract TCC.
So conformity to a geometrical pattern doesn't mean that there's an identity which is attached to it. For instance, a rounded mass is always RCC. It doesn't happen. Yes, it can happen in a way. For instance, benign lesions are mostly circumscribed. They are maybe circular, but again, that doesn't mean that all benign masses are circular. Most of them may be circular, but the geometrical pattern doesn't give you a clue. All these things are things of the past somewhere when CT scan wasn't there. Now, all those images that we see in histopathology atlases are taken by CT scan as well as through electron as well as light microscopy. So the things have changed. Things have changed according to what the actual fact is rather than intuition. Earlier, it was the imagination or intuition or experience of a single person. Now, technology has replaced a single person's experience to a million persons' experience, right? And AI is something which is going beyond that. So your mind should be open because turning of a cell into a malignant cell is always seen through the nucleus, the pleomorphism, the nuclear atopia. So it's not the bizarre shape of the cell wall. It is something which is inside the nuclear wall.
Paraneoplastic syndromes associated with RCC found in 10 to 20% of patients with RCC, defined as clinical syndromes involving non-metastatic systemic effects. It is very important to evaluate for paraneoplastic phenomenon because they can be a source of major morbidity and can affect clinical decision making. Elevated ESR levels are found in more than 50% of identified paraneoplastic syndromes. Usual associations include hypercalcemia, occurs likely to overproduction of 1,25-dihydroxycholecalciferol, reported in up to 13% of patients, and can be due to both either paraneoplastic phenomena or osteolytic metastatic involvement of bone. Non-specific signs and symptoms are present such as nausea, fatigue, anorexia, and decreased sleep tendon reflexes. Medical management includes vigorous hydration followed by diuresis with furosemide. Bisphosphonate therapy is now considered as standard of care in such patients until renal functions are normal. More definitive managements include nephrectomy and occasional metastectomy depending on the clinical circumstances. Hypertension can be either due to overproduction of renin directly from the tumor or due to compression or encasement of renal artery leading to renal artery stenosis. Polycythemia, increased production of erythropoietin either directly by the tumor or by the adjacent parenchyma in response to hypoxia induced by tumor growth. Stauffer syndrome. It is defined as non-metastatic hepatic dysfunction reported in 3 to 20% of the cases. Majority have elevated prothrombin time and hypoalbuminemia. Elevated ALP levels. 20 to 30% have elevated serum bilirubin and transaminase levels. Symptoms include fever and weight loss. Hepatic metastasis must always be excluded. Biopsy, when indicated, often shows non-specific hepatitis and discrete regions of necrosis occasionally. Nephrectomy usually leads to resolution of hepatic dysfunction. Persistence or recurrence of hepatic dysfunction is almost always indicative of viable tumor and thus shows poor prognosis.
Dysfunction in Stauffer syndrome. Is there any underlying pathology or any changes that causes the liver dysfunction? What are those?
These are basically due to metabolic oxidants which are produced by the tumor cells. Interleukin.
Other less common paraneoplastic syndromes. The less common but distinct paraneoplastic syndrome associated with RCC include Cushing syndrome, hyperglycemia, galactorrhea, clotting disorders, and cerebellar ataxia. In general, treatment of paraneoplastic syndrome associated with RCC has required surgical excision or systemic anti-neoplastic therapy. Except for hypercalcemia, medical therapies have not been proved helpful. The TNM staging system has replaced the Robson system. Tumor T stage is based on the size and extension of cancer into the renal or extrarenal structures. Pathologic stage is most important prognostic factor for RCC. T stands for size of the tumor and spread to nearby tissue, and spread to nearby lymph nodes, and M for metastasis. So T1 includes tumor 7 cm or less confined to the kidney. T1A, tumor size less than 4 cm. T1B, tumor size more than 4 cm but less than 7 cm. T2, tumor greater than 7 cm but confined to the kidney. T2A, less than or equal to 10 cm. And in T2B, tumor mass is greater than 10 cm. In T3, tumor extends into major veins or paranephric tissues but not into adrenal gland or beyond Gerota's fascia. T3A extends into the renal vein or branches of perirenal sinus fat but not beyond Gerota's fascia. T3B extends into vena cava below the diaphragm, and in T3C extends into the vena cava above the diaphragm or invades the wall of the vena cava. T4, tumor invades beyond Gerota's fascia including into the adrenal gland. Regional lymph nodes. N0, no regional lymph nodes, metastasis. N1, metastasis in regional lymph nodes. Distant metastasis. M0, no distant metastasis, and M1, distant metastasis present. Anatomic stage and prognostic groups. Stage 1 includes T1 and not M0. Stage 2 includes T2 and not M0. And stage 3 includes T1 or T2 with N1 but M0. T3 N0 or N1 or M0. Stage 4 T4 any N, any M or M1. So now the renal mass biopsy. Percutaneous age-guided biopsy of renal masses is a safe and accurate procedure previously only reserved for the diagnosis of unresectable renal cell carcinoma, metastasis, lymphoma, and infection. There is increasing awareness that substantial proportion of small solid renal masses are benign neoplasms. Although imaging can be used to diagnose most of them, but some are incorrectly believed to represent renal cell carcinoma, and unnecessary surgery may be performed. Based largely on advances in cytological techniques, percutaneous biopsy can now be used to diagnose benign neoplasm and thus prevent them from being treated unnecessarily. So now we will watch the video of CT guided biopsy of the renal mass?
Lesion is performed under image guidance, commonly CT or ultrasound guidance. It is often performed on an outpatient basis. The patient lies on the procedure table. The initial CT images are obtained. The location of the lesion in the kidney is determined. The biopsy device cannula entry site is marked on the skin. Then, the access site is sterilized. The access area is covered by a surgical drape. The skin and renal capsule are numbed with a local anesthetic at the access site. A very small nick may be made in your skin to make it easier to pass the needle into the renal lesion. Then, the tip of a cannula is placed within the renal lesion under CT guidance. The biopsy device is prepared and then advanced through the biopsy cannula into the lesion. Subsequently, multiple passes are performed to obtain required tissue samples. The entire procedure usually takes between 30 to 60 minutes. At the end of the procedure, the biopsy cannula is removed and pressure is applied to stop any bleeding. Subsequently, dressing is applied at the opening on the skin.
Indications of renal mass biopsy. According to EAU guidelines 2022, renal mass biopsy should be done in following cases: to obtain histology of radiologically indeterminate renal masses, to select patients with small renal masses for active surveillance, to obtain histology before or simultaneously with ablative treatments, to select most suitable form of medical and surgical strategy in the setting of metastatic disease. Renal biopsy is not indicated for comorbid and frail patients who can be considered only for conservative management regardless of biopsy results. The procedure. Procedure can be performed as an outpatient procedure at a hospital, mostly done in radiology department, as an ultrasound or CT scan is needed during the procedure. A percutaneous route is the most common mode of biopsy. A biopsy needle is passed through the skin to remove tissue from renal mass under radiological guidance. Technical details and complications. When performing a renal mass biopsy, consideration should be given to several technical factors that may affect the diagnostic and complication rates. The guidance modality that best depicts the lesion, adjacent structures, and the needle tip should be used to guide the biopsy. Each modality has its advantages and disadvantages. Ultrasound provides real-time imaging without ionizing radiation but may not visualize the lesion. CT is more expensive, however, usually allows better depiction of the mass and surrounding structures. MR imaging is seldom used, but may be helpful to biopsy a mass that is not seen by ultrasound or CT. Operator preference and equipment availability will also play a part in deciding which imaging modality is chosen. The diagnostic effectiveness. The purpose of percutaneous biopsy is to obtain a tissue diagnosis safely. The biopsy results should have implications on patient management. Therefore, obtaining a benign diagnosis is as important as malignant one. The absence of malignant cells from a biopsy, however, does not necessarily confirm benignity and should be viewed with caution. Sensitivities and specificities for renal mass biopsy range from 80 to 92% and from 83 to 100% respectively. False negatives likely due to inaccurate needle placement or obtaining necrotic tissue. False positives rare and much less frequent today due to advances in cytology. Complications of renal mass biopsy. Hematoma being the most common 4.9%, gross hematuria, hemorrhage requiring transfusion, clinically significant pain, pneumothorax, pseudoaneurysm. Overall, however, renal mass biopsy is a safe procedure. Most hemorrhages are subclinical, detected as standing a small hematoma at CT and self-limited, and can be successfully managed conservatively.
Sir, when the patient has got the small renal mass and we are planning for surveillance, or the patient has got, or we are planning for any systemic therapy, so we must have diagnosis beforehand, and there's we are suspecting like it's any other tumor or any indistinct tumor. So we'll get the biopsy.
Which I previously mentioned is most of the time it is a radiological diagnosis, right? If a patient has an RCC, you know that. And what are the indication for biopsy in those patients?
So if it is metastatic disease and we are
Yeah.
planning for systemic therapy,
So it could be bilateral. Say, if there is a bilateral mass, you can have like a
we can choose
for
for another
confirmation.
modality.
Yes, it's a metastatic disease where you're planning for some systemic therapy, right? And if the other scenario is that if it is not radiologically distinct and you want to save the nephrons, and another indication is your newer modalities like HIFO and things like this. There are some techniques where you don't find a tissue after that modality for small renal masses, SRM. For those cases, you have to do the biopsy and know the nature of the disease, and then you can go for all out management.
Okay, guys. Thank you, everyone.